Okay, so here we go. So let's look at joints. So joints are also known as articulations because this is where bones come together to articulate. And you will find that in many joints movement is allowed, in some of them no movement is allowed, and then we call them immovable joint. So the point of contact is usually between two bones, but sometimes you will find that there could be cartilage and bone. So the articulation could be between cartilage and bone, and one example is like the wrist joint. So when we look at that, I'll show it to you. So first we'll begin with classifying joints. So for the two ways we classify joints are based on movement and based on what intervenes between the two articulating bones. So based on movement, the first one is a joint which is absolutely immovable. Such a joint is called synarthrosis. And if you think of it, the way you're going to remember, the word arthrosis is to do with joints. The word syn means together. So it's like these joints are fused. Okay? So one way to think of it is these joints are fused. Syn meaning together, arthrosis is for joints. So where the joints are fused together, such an example is an immovable joint. Because they are fused, you cannot move. Second example is a joint which is partially movable. Such a joint is called amphiarthrosis. And third is a freely movable joint. And the way you'll remember that, diarthrosis. Arthrosis again for joint, and I couldn't think of anything better to say. It's like to die for. You can, so that you're freely movable all over the place. So that's the way you're going to remember, okay? Freely movable, diarthrosis. Now based on intervening substance, so what kind of tissue intervenes between the two joints, we classify them in three ways. If fibrous tissue is present between the joints, if there are two bones like this, and there's fibrous tissue present in between them, such a joint is called a fibrous joint. It just so happens that fibrous joints are also seen to be immovable. So one way you want to write, you might want to just add it up here. Immovable are synarthrosis. Most fibrous joints are immovable, so you can put it up there. Some of them have a little bit of movement. We'll go over that when I come to it. Next is cartilaginous joints. So here there is cartilage which intervenes between the two bones. So if these are two bones, you have cartilage intervening. The cartilage could either be hyaline or it could be fibrocartilage. So the cartilage could be hyaline or fibrocartilage. Some of these cartilaginous joints allow a slight degree of movement. So we can put cartilaginous joints up here as amphiarthrosis. So as a general rule, we can put cartilaginous joints here because they are partially movable. Not all of them, some of them. The joint in between the two bones, you either have hyaline or fibrocartilage. The third type of joint is synovial joint. And this previous picture here is a good example. This is a synovial joint where you have this synovial membrane which lines the joint cavity and it produces synovial fluid. So this is a really good example. So synovial joints produce synovial fluid. So in between the joint, so in between two bones, say if this is one bone and this is the other bone here, you have a membrane which produces synovial fluid. So you have this membrane which produces synovial fluid. So there's fluid present inside the cavity. And these joints, again, are seen to be freely movable. So you can add synovial joints here. Again, there are always exceptions. So we will go over that when we come to it, okay? So we could say synovial joints are freely movable for most part, or also called diarthrosis because they are freely movable. Cartilaginous joints have fibro or hyaline cartilage in between the bones, and they are usually classified under the amphiarthrosis. Fibrous joints have fibrous tissue between the two bones, and they are synarthrosis. Okay? So you're combining the two classifications. So let's first look at fibrous joints. So fibrous tissue intervenes between the two or more bones which are articulating. And here we have 3 examples of fibrous joints. And it's given very nicely in this picture. The first one is a suture. You've all done these sutures in the skull. Sagittal suture, the coronal suture, lambdoid, squamous. So all these, if I was to ask you what kind of a joint is the sagittal suture, your example would be fibrous joint, right? Because they are sutures. Fibrous joints, one example of a fibrous joint is a suture. And where are sutures seen? Between cranial bones. So all these sutures that I just mentioned, like sagittal, coronal, lambdoid, squamous, are all between cranial bones. The second type of fibrous joint, and here if you look at a suture, you can see this is fibrous tissue in between the bones. The second type of a fibrous joint is a joint which is called a syndesmosis. And here again you see between these two bones, this is the tibia and this is the fibula, and there's fibrous tissue present between the two. So the example of a syndesmosis is the inferior tibiofibular joint, or also known as the distal tibiofibular joint. Okay? Inferior or distal tibiofibular joint. If you remember, I said when we're doing bones and joints, it's not wrong to use the word inferior instead of distal, or use superior instead of proximal, because we always study bones outside the body, so not in an articulated form, so it's okay to use that. So here you can see that the bones are held together by a fibrous tissue ligament. These joints, especially this inferior tibiofibular joint, normally no movement is allowed. But occasionally it will allow extremely slight degree of movement. And this happens when, for example, you're jumping from a height. Imagine you jump from a height. What happens? You land on your heels, right? When you're landing on your heels, the weight is transmitted from your tibia, fibula, it's going all the way down here like this. If these two bones did not move even slightly, what would happen? The fibula, which is a very narrow bone, it would splinter, it would break. So what happens between these two bones, especially in such a situation where you're jumping from a height and you're kind of landing like this, the two bones just gently move apart, very, very little. And that moving apart is known as the splaying of the two bones. So these two bones will kind of, so I'm going to erase this, so they'll very, very gently move apart. It's not a very perceivable movement. So this is the fibula here, and this is the tibia, and the interosseous, this ligament still keeps them together. Okay? But gently move apart slightly, just to, sort of dissipate that weight, and so that the bone doesn't break. The third type of fibrous joint is what is called a gomphosis, or where your tooth and socket. So here's your tooth, which is lying inside the socket, and the fibrous tissue is this little ligament which attaches the tooth to the socket. This ligament is called this periodontal ligament. This is fibrous tissue. If you've ever had your tooth pulled out, you'll notice, when you have your tooth pulled out like this, you have little sort of things sticking, little fibrous tissue sticking to the end of the root, and that's what this periodontal ligament is. Okay? So here also in this joint, no movement is allowed. But when you chew, again, very, very minimal movement occurs. When you chew your food, a little bit of movement, again, not perceivable. It's not something that you can actually see. Your teeth don't kind of move around in their socket, but there is a very, very slight movement which occurs, which is why we because the movement is so slight, which is why we classify all of these fibrous joints into immovable joints. Okay? So these examples you must know. Sutures, syndesmosis, and gomphosis.
Those three are immovable joints?
Immovable, fibrous joints. Okay, well, I just told you the answer. So do you think movement is possible? No, right? Okay. Let's look at the next type of joint, which is cartilaginous joints. Now remember, I told you that you had hyaline cartilage and you had fibrocartilage. So you could either have hyaline or you could have fibrocartilage. So cartilaginous joints are divided into two categories. One is called primary and the other one is called secondary. In primary cartilaginous joints, it's hyaline cartilage which is present. And that's why looking at a slide is really important, because notice here it says bones united by hyaline cartilage. So here is a good example. We did the skeletal system last time. So here is the epiphysis. This part here is the diaphysis. Between the epiphysis and the diaphysis is this epiphyseal cartilage, or known as the growth plate, right? So can you see between these two pieces of bone is this bit of cartilage? So this is a primary cartilaginous joint. This is also known as synchondrosis. The word syn again means together. Chondra means cartilage. That means the cartilage just comes together. So the joint between epiphysis and diaphysis in any long bone is an example of a primary cartilaginous joint. Another example is the one which is shown here between the sternum, this is the sternum, and the first rib. So this costal cartilage of the first rib, remember the ribs 1 to 7 were true ribs and they attach directly to the sternum. So this costal cartilage actually joins with the sternum, but here this is fused. So you cannot separate that costal cartilage from the sternum. So this sternum and this costal cartilage of the first rib and the first rib, they act as one joint. So that's why it's called synchondrosis. Can you understand where cartilage has fused here to the bone? So that's why this first, what is called the first sternocostal joint between the sternum and the costal cartilage, the first costal cartilage. So these are the two examples. Epiphysis and diaphysis of long bones and the first sternocostal joint. So there's no movement possible at these primary cartilaginous joints. And think about it. Between the epiphysis and diaphysis where this bone is present, is there any movement possible? They don't move. The epiphysis and the diaphysis don't move about, right? Similarly, as I said, there is no movement between the sternum and this costal cartilage because they are fused to one another. So therefore, what happens, these joints, and especially where the epiphysis and the diaphysis, where this cartilage, the bone soon overgrows it, the joint kind of fuses. So it's also, when the joint has fused, it's also known as synarthrosis. No movement possible. Remember, immovable joints were also called synarthrosis. So this primary cartilaginous joints are also immovable joints. And let's answer this question. Do you think this joint between the epiphysis and the diaphysis, do you think it's going to be permanent or temporary? In other words, is the joint going to remain throughout life or it's going to disappear at some time? That's what I mean by permanent or temporary. The joint is temporary, remember, not permanent. And why? Here's why. Remember, the epiphysis, the joint is because the cartilage is present between the two bones. The epiphysis, this epiphyseal plate, remember, ossification occurs at some point, 18 years in females, 20 years in males, usually 21 in male. This epiphyseal cartilage goes away, right? Because bone growth overtakes, ossification overtakes. It's represented by a line. So now there's no joint because it's all one bone. So can you understand how then the joint is a temporary joint? The joint doesn't exist any longer, okay? So this is a temporary joint, not a permanent joint. Let's look at the next type of joint, which is a secondary cartilaginous joint. And again, looking at your PowerPoint tells you all the answers. Look here, bones here are united by fibrocartilage. Such joints, if you remember when we looked there, I told you they are partially movable. So that's why we also call them amphiarthrosis, which means partially movable. Another name for these joints is symphysis. So singular is symphysis, plural is symphyses. So when I'm talking about many of these, they are symphyses. These joints are also known as symphyses or symphysial joints. So these bones are united by fibrocartilage, or the fibrocartilage is the tissue which is present between the two bones. So let's look here at this part here, at the hip bone, at the pubic region. So here is the hip bone. So here is fibrocartilage which is present. Here is fibrocartilage which is separating the two bones. But remember, bones were also lined by articular cartilage. If you remember, we talked about it in relation to long bones. Remember, the ends of long bones were lined by articular cartilage. But here also, wherever there is this joint, this surface of the bone has a thin layer of articular cartilage, which is hyaline. But here, in between, is this fibrocartilage, and that's why it's also called a fibrocartilaginous joint. Okay? This secondary cartilaginous is also known as a fibrocartilaginous joint. The intervening tissue is fibrocartilage, because this is the intervening tissue here, which is fibrocartilage. This little hyaline cartilage just lines the surface of the bones. It's not intervening between the two bones. Examples of this joint are this one here, the pubic symphysis, which is present between the two hip bones. Another example is the joint between the two vertebrae, which is known as the intervertebral joints. And what is present between the vertebrae? The fibrocartilaginous intervertebral disc. Between two vertebrae, you have this intervertebral disc, which is fibrocartilaginous in nature. So it satisfies this property of secondary cartilaginous joint. So these are the intervertebral joints, which are separated by this intervertebral disc, which is fibrocartilage in nature. Another example is, as I said, these are seen in midline joints of the body. So if you look at it, the pubic symphysis is right in the midline of your body, right? The vertebral column again in the midline of your body. So the intervertebral discs between the vertebrae in the midline of the body. Another example is in the midline is the sternum. So if you look at the three pieces of the sternum, so here is the manubrium, this is the body of the sternum, and this is the xiphoid process. In between these three pieces of the sternum, you have fibrocartilage which is present. Here and here. And of course, the surface of the bones is, this surface will be lined by that articular cartilage. Here also it will be lined by articular cartilage, here also and here also. But here you have the fibrocartilage. Again, your sternum is in the midline. So this joint between the manubrium and the sternum is known as the manubriosternal joint. Between the manubrium and body of the sternum, it's called manubriosternal joint, and this one between the xiphoid process and the sternum is called the xiphisternal joint. So again, can you see in the midline? But why am I calling it amphiarthrosis? In other words, partially movable. I'm sure you're thinking my pubic symphysis never moves, right? It doesn't move normally. But again, especially during pregnancy, women tend to produce a hormone called relaxin, which tends to make the ligaments a little lax. And during childbirth, there again is a slight separation in the pubic symphysis. You all know at the vertebral column, you can bend backwards and forwards and sideways, right? You can flex in front, extend at the back, bend sideways. So again, there's slight movement which is possible at the intervertebral joints. And then between the three pieces of the sternum during respiration, actually the three pieces of the sternum, there is a movement which is possible. The sternum actually moves a little bit forwards. So again, between these three types of joints, movement is possible, but the movement again is not so great, but it's still there. and it occurs, throughout our life. So therefore, these joints are known as amphiarthrosis or partially movable because they don't have a free movement. They have slight degree of movement, so that's why we call them partially movable joints. Okay?
So all of the partially movable joints are lined by the high line, just
Yes, all of these joints will have articular cartilage, but the intervening tissue will be fibrocartilage. Yes. Then we have synovial joints. So these joints, we call them synovial because you have this synovial membrane. This is the synovial membrane. The synovial membrane is exactly like, remember when we did, right in introduction, we did serous cavities like your pleural and pericardial and peritoneal, and they produce thin fluid. So the synovial membrane is also a serous membrane which produces thin fluid. And if you remember, what was the function of pleural fluid, of pericardial or peritoneal? What was the function? Pardon? Lubrication, right? So similarly here, synovial fluid also lubricates the joint. So can you see two bones up here? Again, the ends of the bones lined by articular cartilage. So can you see wherever joints have a little movement, you will always find articular cartilage lining the ends of the bones, like you saw in the fibrocartilage. There was slight movement, so that's why you have this articular cartilage, because you don't want bone to be rubbing on bone and, wearing it out. This joint cavity is filled with synovial fluid because a lot of movement occurs. Because remember, synovial joints, we said, were diarthrosis, right? They were freely movable. So because a lot of movement is occurring at this joint, you want lubrication there. You want them well oiled so that bone doesn't rub against bone. So you have articular cartilage plus another added thing, which is this synovial fluid. Then these joints, what holds the joints together is a capsule. So there's an articular capsule which kind of surrounds the whole joint and keeps the joint together. And the inside of the articular capsule, so can you see this sort of grayish area is this fibrous layer of the articular capsule. The inside of the articular capsule is lined by this synovial membrane. So that's how it's going to be able to secrete into the joint. Because a lot of movement is present at this joint, you want to make these joints strong. So these joints often have ligaments which are present. These ligaments may be part of the capsule itself. So you may have some ligaments which are kind of part of the capsule like this. Or you may have ligaments like this which are present on the outside. And what ligaments do is they connect bone to bone. So you can see how these ligaments are connecting bone to bone. And then I mentioned articular cartilage. You can see it has this articular cartilage. The idea of the articular cartilage is to protect the underlying bone, cushion it, protect it from undue stress. So it cushions any weight on it and any movement, so that bare bone doesn't rub against bare bone. In fact, when you have a condition called arthritis, especially something called osteoarthritis, which happens it's an age-related kind of arthritis. Arthritis means inflammation of a joint. In that, as we get older, because for so long your bones have been creaking against each other, this articular cartilage is worn off. And so actually bare bone is exposed. So you can see how painful it is going to be to rub against, bone rubbing against bone. Now, in some synovial joints, you have fibrocartilaginous bits of or pieces, or what are called discs. These are known as either they are called articular discs because they are present inside a joint, or in the knee these are known as menisci. So what are these articular discs or menisci? These are fibrocartilaginous bits which are present inside the joint. So for example, in the knee joint, you will have a fibrocartilaginous disc which is present inside like this. It's known as a meniscus. So it's present inside like this here. inside the joint cavity itself. Okay, so this is a meniscus which is seen in the knee joint. It is fibrocartilage in nature, and I have a picture showing you that. So it's present inside the joint cavity. It will be inside the capsule. Obviously, the capsule is the outermost structure, right? It's the bag which covers it on the outside. These menisci, they kind of help, which you'll see in the next picture, they help to make one bone fit well into another bone. So they kind of help to the contour of one to fit into the other well. And you'll see, again, I'll show it to you in the next picture. In some synovial joints, you have fat pads. You'll see a little pad of fat which is present. These little asterisks just tells you that not every synovial joint will have an articular disc. Not every synovial joint will have a fat pad. Some of them do. That's why I have them. And then some synovial joints have little bags present around them which may communicate with the joint, or they may be separate from the joint. These bags which contain synovial fluid, these are bags which contain synovial fluid and they help to prevent friction. These are known as bursae. These are called bursae. So bursae are nothing but little bags or pockets of synovial fluid which are present around synovial joints, and they help to prevent friction. So wherever you will find this, wherever there is a tendon which is passing over a joint, and that joint is very freely movable, that tendon could rub against bone, so you'll find a little bursa. It's like a little balloon, water balloon present there, so that it kind of helps to prevent friction. When I show you the next image, you'll see this. Synovial joints have a very good nerve and blood supply. Fibrous and cartilaginous joints, not so richly supplied with nerves. Blood supply is okay with them because, bone always has a good blood supply. But synovial joints usually have a very rich nerve supply, and you'll find usually around freely movable synovial joints, the arteries tend to kind of join each other and they form a network, so that when the joint is moved, there's no kinking of the blood vessels. Okay. So, which of these state, now you might get a statement like this, which I'm just here trying to tell you that you must read a question very, very carefully. Don't get excited when you look at a question and you think, oh, I know this. Read it carefully. So if you think you don't find a wrong answer, that means you have to go back and read it again. Okay, half the class got it right. Now look at it. The synovial membrane does secrete synovial fluid. Remember I said it was a serous membrane. It's the one which secretes the fluid. The fluid does act as a lubricant. That's why it's there. It lubricates the joint, prevents friction. Articular cartilage does cushion the ends of long bones, right? We saw that. The synovial membrane lines the inside of the articular capsule, not the outside. So this is where it was wrong. So look here. That's why looking at the picture, can you see the articular capsule is the outermost structure? It would make no sense for the synovial membrane to lie outside, because then it would pour its secretions outside the joint, not inside the joint cavity. Okay? So this is why you must look at these questions carefully. Now here is a description of menisci and bursae. So here is the meniscus in the knee joint. I mean, you've all probably heard of a medial meniscal tear. Medial menisci are prone to tear very frequently because they are very firmly attached to the capsule. So here you can see this is the meniscus. Can you see it's kind of C-shaped, and can you also see it's kind of got like a dip, it's shallow, so that this helps, this is present on the surface of the tibia, and the femur, its surface will kind of go over it like this. Can you see how it helps to make the contours of the bone fit into each other really well. So it kind of holds it like a cup and helps the femur sort of articulate well. So that's one function of the meniscus. Another one is it's present inside the joint cavity. It helps to actually even spread the synovial fluid. So it helps to spread the synovial fluid. And it actually also, especially in the knee, it allows, because it kind of divides the joint cavity into two, it allows an extra or increases the range of movement. So range of movement is increased. So because, remember, it's in between the joint cavity, so there is a part above the meniscus, there's a part below the meniscus, so certain movements can occur above, certain can occur below. That's a bit complicated, but just for your interest, what is the purpose of this meniscus? How does it help, apart from just making the articulation better? Spreading the synovial fluid and increasing the movement in the knee joint, which is why we call the knee joint a modified hinge joint. When we do the types of joints we'll see, we call it a modified hinge joint, because you can do more than just flexion extension in the knee. Now here is an example of, imagine this is a joint where the capsule has been removed. So, this is where the capsule would have been. So it would have been on the outside like this. Okay. And now you remove this capsule, and now imagine you can see inside. So here is the synovial membrane, and inside would be the synovial cavity. So here is a little bursa. Can you see this little pocket going out? And that's because there is a big muscle which attaches here. And this muscle passes across and goes to the humerus this way. So this muscle will constantly rub on bone if this bursa was not there. But because this bursa is present between the muscle and bone, it helps to reduce friction. Otherwise, there would be too much wear and tear on that muscle. Here's another example. There is this tendon of a muscle called the biceps. This tendon comes and lies in a little groove present on the humerus. So if the tendon was allowed to remain there, every time you flexed your elbow and you moved, and caused the biceps to act, this tendon would keep sort of rubbing along in that groove, and it would get worn out. So now, to prevent that from happening, can you see there's this little sheath which is known as a tendon sheath, or also known as a synovial sheath, and that kind of acts like a little water balloon or water bath around the tendon and prevents friction. Okay, so that's the purpose of these bursae. You had a question?
The meniscus, or the menisci, is considered a synovial joint, which is freely moving, but the meniscus only moves in a couple of directions.
The meniscus is not a synovial joint. The meniscus is something which you see inside a synovial joint. These were all properties of synovial joints, these. The meniscus is something which you see, like articular cartilage is something you see in a joint, like that. In synovial joints, in some synovial joints, you might see a meniscus.
Okay.
So it's not the joint. It's just a part of the joint. It's like synovial membrane is part of the joint, right? So similarly, a meniscus. So the meniscus doesn't do the moving. It's the joint which does the moving. Okay. Now we've been talking about movements. So let's look at what are the movements that we have. So if I was to tell you to flex your elbow, all of you are capable of doing that, right? How would you flex your elbow? You just bend your elbow and the angle between your forearm and your arm reduces, right? That is, flexion is like a bending motion. Extension is the opposite. You where the angle decreases. And where the angle increases, that is extension. Where the angle decreases, we call it flexion. So flexion is a bending motion, extension is an unbending motion. Then we have a movement which is known as abduction, and another movement which is called adduction. Abduction is a movement where you move away from the midline. When you're going away from your midline, like for example, if you're standing at attention with your arms by the side of your body and you lift your entire upper limb to go away from the midline, that is abduction. Or when you stand at ease, when your feet are further away from each other, that is abduction, away from the midline. How will you remember it? Think of it, abduct, like aliens abducting you, what do they do? They take you away. So your limbs go away from this midline, okay? That's abduction. Adduction is when you're going towards the midline. So when you're adding something, what you do? Bringing together. So towards the body, towards the midline. Rotation, this is simple. Imagine, you've all seen the Olympics and you've seen someone sort of rotating, especially these ice skaters, going around like that. So they are rotating. So in rotation, you have something known as internal and external, or internal is also called medial, and external is also known as lateral rotation. So we say internal or medial rotation when the bone which is moving, when the anterior surface of the bone, so let's take this bone, the humerus, the anterior surface of the humerus moves towards the midline. That's called internal rotation or also called medial rotation. So when this is the anterior surface, when I rotate it towards the midline, that is internal rotation. So if I was to show you, imagine this way, okay, going this way, this is internal rotation. When it moves away from the midline, when it goes the opposite direction, that is external rotation. So when the anterior surface moves away from the midline, that is external rotation. For example, if you had your forearm flexed at 90 degrees and it was across your belly like this, and you took your this forearm away from your body, this is external rotation, and you bring it towards your body, this is internal rotation, okay? Now all of these movements, flexion, extension, abduction, adduction and rotation, they occur along an axis. So imagine putting a pin through a part of the joint and then you say the movement occurs on either side of the axis. So look at this movement. This is flexion extension. It occurs along a transverse axis. So can you see this pin has been put transversely across the shoulder joint? So flexion is going up, extension is going the other way. Think of it in the elbow. So if in the elbow we have the humerus and the radius and the ulna like this. And if I put a pin right across here at the elbow joint, transverse axis, flexion would be when these two bones go up. So if I look at it from the side, this is what flexion would be, right? That's supposed to be my hand. And extension is when it goes the other way down, when it goes down this way, right? So again, transverse axis. So flexion and extension occur along a transverse axis, okay? Abduction and adduction occur along an anteroposterior axis. AP stands for anteroposterior axis. Anteroposterior axis. So imagine, look at this pin. This pin has been put through the joint going from anterior to posterior. See this? From the front to the back, from anterior to posterior. So abduction is away from the median plane, adduction is towards the median plane. So can you see if you put a pin through, abduction on one side of the axis, adduction on the other side of the axis, okay? So abduction, adduction occur along an AP axis, and a good way to remember it's both A and A, so AP axis, okay? Rotation, think of it, imagine you putting something right through the center of your body. So in this case it's center of the bone, and you're rotating around that axis. So this is a vertical axis. So rotation is pretty simple. Imagine somebody on an ice skater going around doing pirouettes like that, rotating around a central axis, right? Or a vertical axis. So along the vertical axis you have the movement of rotation. So let's look at these shown really well over here. They have a slight different terminology. Don't get confused, and I'll kind of explain that. So let's look at this.
Reference planes are more specific. Other sagittal planes is referred to as the top and bottom portion. They are human plane about an axis. There are three axes that we will be discussing: the frontal horizontal axis, the sagittal horizontal axis, and the vertical axis. When a person is walking, that individual is moving in the sagittal plane. It can be also described.
Now, here she's talking about which plane you're moving, so just ignore that. Just listen to the word axis here, okay?
Plane. It can be also described as moving about a frontal horizontal axis. Other examples of moving in the sagittal plane about a frontal horizontal axis would be performing a squat or even a leg raise.
See, in all of these, can you see it's flexion, extension that you're doing around? She's called it a horizontal axis, same as a transverse axis, okay? So when you're doing a squat, when you're lifting, you're flexing your thigh. Here you're flexing your knee, and then you are flexing your elbow, so along a transverse axis or a horizontal axis, okay?
All of these movements can be classified as either extension or flexion. Persons performing jumping jacks, they're moving in the frontal.
So here, can you see it's going through the body from front to back in an antero-posterior axis. Can you see that? Okay.
Plane about a sagittal horizontal axis. Other examples of moving in the frontal plane about a sagittal horizontal axis would be a cartwheel or working the adductor muscles in the inner thigh. These movements can be described as either abduction or adduction. The last axis left to discuss is moving in a horizontal plane about a vertical axis. If an ice skater spins, they are moving in a horizontal plane about a vertical axis. Other examples may be shaking your head no, or twisting the spine while the feet are planted on the ground. Moving in the vertical axis requires rotational movements. To recap, flexion.
So here are some of these movements which are shown. So here you can see flexion, you can see at the knee, the angle between the joint, the bones which form the joint decreases or the ventral surfaces come together. Extension is the opposite when you kind of make it straight. Abduction is taking it away from the median plane. Adduction is when you're bringing it towards the median plane. Rotation, remember I said medial rotation is when the bone's anterior surface rotates towards the midline, and lateral rotation is when it goes away from the midline. And then we have another movement which is known as circumduction, which you can see here. Circumduction is not a separate movement. It's just a combination of movements. So when you're doing this, when you swing your arms around in a circle like this, you're actually moving all. You're doing flexion, abduction, extension, adduction, rotation. So it's a combination of movements, okay? So the three movements are only flexion, extension, abduction, adduction, medial and lateral rotation. Circumduction is not a separate movement. It's a combination of movements. So how about this? Standing at ease with the legs apart. What is this an example of? Abduction, yes, very good. So when you stand at attention, then that is adduction. So, when you're doing jumping jacks, when you're kind of spreading your legs apart, that's an example of doing abduction. And what axis does abduction and adduction take place in?
Midline.
Yeah, but what do you call that?
Away from the midline.
No, but what axis? That's the definition. What axis does it take? AP. Remember abduction, adduction, you have the A, so AP axis, yes. So here are some other movements which take place, and these take place at specific areas, so they're not seen in all joints. One is this movement which occurs in the forearm, which is the movement of pronation and supination. Pronation is a movement where the radius moves over the ulna. It's a rotatory movement where the radius moves over the ulna and your palm faces down. So you can see where the radius here has moved over the ulna and the palm is facing down. So the forearm bones are kind of one over the other. Can you see that? That is pronation. So from this comes the word prone. When somebody tells you that lie prone, you're actually lying on your stomach. The second one is supination, which is the opposite, where the radius and the ulna lie parallel to each other. So the radius rotates back and comes to lie parallel to each other. The palm is facing forwards or upwards. Okay? That's why we say supine when you're lying on your back. Yes. So this pronation and supination, for you guys, you can take it to occur only in the forearm. When we do describe it in the foot, but that's more for podiatric and orthotic and prosthetic students. But for you, we will take pronation and supination to occur only at the forearm. Then when we come to the ankle, instead of using the word flexion and extension, everywhere else we use the word flexion where the angle decreased and extension where the angle increased. So at the elbow we use flexion. When you bend your head down, that's flexion of the neck. When you bend at your trunk, that's flexion of the vertebral column. When you lift your thigh up, that's flexion at the hip. When you bend your knee like this, that's flexion at the knee. But when you come to the ankle, we do not use the word flexion and extension. Instead, we change it a little bit. We call it dorsiflexion and plantar flexion. And one way you're going to remember it, because this will help you when you do muscles, dorsiflexion is truly extension at the ankle joint. And right at the beginning in the introductory lecture, I told you how the limbs actually twisted. And so with the results from the knee downwards, you find that, the ventral surface actually went to the back. So because of the way the fetus developed, we don't call this movement of the ankle going up, we don't call it extension. Though it is extension, we don't call it extension, we call it dorsiflexion. And this movement where the ankle goes down, this movement is called plantar flexion, and this is true flexion. It would be useful for you to remember this, because when we do the muscles, for example, then you'll see that all the flexor muscles will be present at the back and all the extensor muscles will be in the front of the ankle. So this dorsiflexion and plantar flexion, this is something that occurs at the ankle joint. Then we have movements which occur at the tarsal joints of the foot. So they occur at the tarsal joints of the foot, not at the ankle. These movements are ones which are known as inversion and eversion. Inversion is a movement where the soles face each other. When you're standing along the lateral border of your foot, where the soles face each other. Eversion is the opposite, where you're standing on the medial border of the foot and the soles face away from each other. Okay? So this is what it's showing. So see, you're standing along the lateral border of your foot and the sole is facing towards the midline. So it faces towards the midline, or if you did it with both feet, then both the soles will face each other. And eversion is when you're standing along your medial border and the sole is facing away from the midline. This is a movement which occurs in us, and it really helps us to walk on uneven ground. If you've ever seen, walked on rocky grounds, you can see how your foot twists like this, and that kind of helps this movement of inversion and eversion. And it does not occur at the ankle joint, because the ankle also is a hinge joint, which only allows one kind of movement. This occurs at the tarsal joints.
So then why is it that when you break your ankle, you lose some of that ability to be able to turn your foot in and out?
Well, the point is when you damage your ankle, the injury is not only limited to the ankle. There are other joints below that which also get affected. So that's why till that healing occurs, you can't, because when you're doing this, when you're twisting, you have to pull on these you've got to be pulling on these ligaments. So these ligaments are related to the ankle, so you can't do that. So till that heals, you can't carry out any other movements, because they're all close to each other. That's why. Okay, so now let's look at synovial joints. So we talked about, if you remember, we talked about those axes, the transverse axis along which flexion extension occurred, anteroposterior axis along which abduction adduction occurred, and vertical along which rotation occurred. So we call joints where you have movement along one axis, we call it uniaxial joint. If the joint can move along two axes, we call it biaxial. If it's along all three axes, we'll call it polyaxial or multiaxial. But there are some synovial joints which do not move along any axis. All they do is just a simple gliding movement. So, we can't put it in any kind of an axial joint. So that's why we call it non-axial joint. That means they do not move along any axis. These are called plane synovial joint because the surfaces, if you look at these surfaces, they are flat or plane. And all they have is just a simple gliding movement. So can you see these bones are just gliding over each other? Very, very simple gliding movement is possible at these synovial joints. Good examples of these joints are the joints present between the carpal bones, between the tarsal bones. So you can see here between the carpal, so these are intercarpal bones. If it was the foot, it would be the intertarsal bone. So this is where gliding movements occur. So these are plane synovial joints. You also see if you remember the vertebrae, and when you must have done it in the lab. If you remember, the vertebra has a part like this, and this is the spinous process. Here's another vertebra, and it articulates with the vertebra above and the one below. So these joints between the two vertebrae here, these articular surfaces, that also is a plane synovial joint. So again, there's a very little slight gliding movement which is present between those areas. Let's now look at joints which move along one axis. So these are called uniaxial joints. So they can perform only one kind of movement. And in this, we have two varieties. One is called the hinge joint, which allows the movement of flexion and extension to occur. So this movement will be along which joint? Which axis? Transverse axis. Very good. Transverse axis. So flexion, extension, so movement along transverse axis. Examples of such joints, so these joints are here, you can see here. So only it's like a hinge. A hinge in a door, you can open or close the door. So same way, you can either do flexion or you can do extension along a transverse axis. Good examples are your elbow between the humerus, radius and ulna. Another example of flexion and extension is this interphalangeal joint. If you look at your fingers, these little lines which are present here between the proximal, middle and distal phalanges, these are called interphalangeal joints. So if you look at your fingers, right, this is the proximal phalanx, middle phalanx, distal phalanx. This joint between these two, these are known as interphalangeal joints. Okay, so those joints here, at these joints again, you can only do flexion or extension. You can only do flexion or extension, okay? So interphalangeal joints. And you'll notice against knee and ankle, I've kind of have a little asterisk because these are modified hinge joints. So we can put them in hinge joints, but we call them modified because the knee, in certain positions, the knee is capable of a little rotation. And even the ankle, when you dorsiflex, you cannot do anything with the ankle. But when you plantar flex your ankle, you can actually move it side to side a little bit. So because of that little additional movement, we say it's a modified hinge joint. But truly, even so, the main movement is only flexion and extension, okay? So you must know these examples. Because the kind of question you could get would be, which of these is an example of a hinge joint? I might give you elbow, shoulder, metacarpophalangeal and atlantoaxial. So obviously you would say elbow joint. Yes. Yes, you have a question?
So AP axis would be abduction and
AP axis is abduction, adduction.
Which is arm and leg. Like when you
At the shoulder and the hip. Yes, at the shoulder and the hip. So, and another kind of question could be, the hinge joint allows what kind of movement? So, your choices would be whatever, and your answer would be flexion extension. Or another kind of thing is, in which axis does a hinge joint allow movement? So it would be transverse axis. You see that? So that's why it's good to write all this at the same point. The pivot joint is also an example of a uniaxial joint, but here the movement it allows is rotation, which occurs along which axis? Vertical axis. Remember that ice skater right through the center, and that's how she's rotating, spinning around, okay? Pivot joint is a vertical axis. The movement is rotation. Examples of the pivot joint are this atlantoaxial joint. This is between the atlas vertebra, the first cervical vertebra, if you remember, is called the atlas. And then below that is the second cervical vertebra, which is called the axis, and it has that little process, if you remember, which was called the dens. So when you say do this movement of no, when you turn your head from one side to the other saying, no, I don't know that, right? That's occurring at the atlantoaxial joint, and can you see it's a rotatory movement like this, where the atlas is going around the axis, okay?
And you said it was at the
atlantoaxial joint. And the other example is the radio-ulnar joint. That means between the radius and the ulna in the forearm. And here I just told you just a little while ago that the movement of pronation and supination, which was a rotatory movement where in pronation the radius rotated over the ulna, in supination it went back. So that is the other example of a pivot joint. So the two examples which you have are atlantoaxial and radio-ulnar. In radio-ulnar, the rotatory motion has a separate special name, which is pronation and supination. In atlantoaxial, it's a typical rotatory movement of, turning your neck from side to side. So this occurs along a vertical axis. So again, the kind of question you might get is, a pivot joint allows movement along which axis? So it would be vertical. What kind of movement is allowed by a pivot joint? Uniaxial, biaxial, multiaxial. It would be uniaxial. Or what kind of movement is allowed by the pivot joint? Flexion, extension, rotation, or abduction, adduction. So you can see it would be rotation. And give an example of a pivot joint, and you can see it radio-ulnar or atlantoaxial. Okay? Okay. Let's see now. Everybody should get this right. I just told you. I still got some people saying the other axis. Vertical axis, pivot joint allows rotation in a vertical axis, okay? In a transverse axis, it's flexion, extension. In an anteroposterior axis, it's abduction, adduction. So it's a vertical axis. Okay, we'll stop here and we'll continue with this